So I think for background, um, patients with muscle invasive bladder cancer are historically treated with chemotherapy followed by surgery. A small group of patients is treated with chemoradiation. Um, most patients have some sort of bladder-directed therapy, and as a result, quality of life suffers. So our whole premise really for the trial was to see if we can preserve bladders for patients. It's that simple. And the idea is if you have an excellent response to neoadjuvant chemotherapy and eliminate all disease, can you avoid a cystectomy? And so this has been looked at in retrospective studies in the past, where patients who have a really good clinical response can sometimes avoid a cystectomy and do well for many years. This was a prospective then study of this, and we thought that we would add in a molecular characterization, see if we can have molecular alterations help us make a decision of who should go into surveillance or not. And we leaned on the work of folks like Dr. Plimak and Rosenberg that have shown that certain genes, mutations in those genes, predicts a really good response to neoadjuvant chemotherapy. So we used ATM, FANK, and RB1 genes related to the DNA damage repair pathway, and then ERCC2, which is a DNA helicase repair pathway gene. All of those genes have been shown to be associated with a really good response to neoadjuvant chemotherapy. So then at the time of surgery, you look in, there's no more cancer left behind, and good long-term survival. So we said, all right, let's start with a cystoscopy where you resect all the tumor, test that tumor for those mutations while you're getting chemotherapy, 3 cycles of accelerated MVAC. And then at the end of it, if you have one of those mutations on your tissue and you have a complete response, which means no cancer on imaging, no cancer on cystoscopy, negative cytology, you can go on active surveillance. And if you don't, then you go on to bladder-directed therapy, whether it's a cystectomy or radiation. And so that was the premise of the trial. And the statistical design was a non-inferiority design. We wanted to show that in the whole group of patients, including patients who go on active surveillance and those who do not, the 2-year metastases-free survival, that was our primary endpoint, is within a certain bounds of what we would expect historically. And so we said that the 95% confidence interval, the lower bound of it, has to be over 64%. And if it is, we would declare the trial successful. And if it's not, we would not. That's how we set the trial up. There are a lot of secondary endpoints: overall survival, rate of developing recurrent disease, for example, patients who are on active surveillance, rate of cystectomy that needed to have happened for patients on active surveillance, quality of life endpoints, association between those mutation and response. So there's a lot of them. Metastases, sort of landmark metastases-free survival, is an endpoint that actually a number of studies in this space have chosen. It is a relatively early endpoint. It's an important endpoint, obviously, especially for urothelial carcinoma. We cannot have an endpoint of pathologic response because not everybody goes on to surgery by definition. So you can't use that, which is an endpoint that has been frequently used in neoadjuvant chemotherapy trials. And overall survival can take a very long time, of course. And metastases-free survival is a good surrogate endpoint, we think, certainly for urothelial carcinoma for overall survival. And a lot of times these events happen early on within the first couple of years. So that's why we've chosen the landmark 24 months overall survival, metastases-free survival. One certainly can choose a 3-year metastases-free survival. But for example, data presented at GUSC as well by Dr. Galsky from the Hoosier trial used the same 24 months metastases-free survival, and it's the endpoint for a few other trials, such as Retain 2. So the first question is, what was the 24-month metastases-free survival rate, the landmark? And it was around 72%, which means that 72% of patients in the whole group of folks, all 70, were metastases-free, did not develop metastases, right? That's the point estimate. But what we look at is, if that's the point estimate, if you go to the left of it and you do this lower bound of the 95% confidence interval, where is that point? That's really the statistical question. And it has to be above 64%, where we would say, okay, we're pretty confident that our estimate is correct. It's not too broad, and it's within the historical sort of reasonable rate of 2-year metastases-free survival. Whereas if our confidence interval gets too wide, goes way more to the left, we really can't be sure that the metastases-free survival rate is what we're saying it is. And so it really depends a lot on how you set up your statistics and what you set up as your definitions and benchmarks. And the way we set it up is utilizing prior data. So we use, for example, the 78% metastases free survival from an accelerated MVAC trial published by Dr. Plimak in 2014 in JCO. And we had our lower bound of around 64% based on a couple of retrospective works published in the journal Cancer around 2012. And that's where we kind of got our numbers from. But what we got was a lower bound of 62.3 or 4%. So it was just below that 64 mark. And so we're saying, you know what, our confidence interval is too low, too wide, in the wrong direction to call this non-inferior. So that's why you have that double negative, not non-inferior. You can't, statistically, you have to be very careful how you phrase it, because if you phrase it in a more simple way, it becomes technically incorrect to say it that way. So in other words, you didn't hear me say it is inferior, okay? Because that's not how the statistics are set up in a non-inferiority trial. So the best you can say is not non-inferior, okay? But I think another easier way to say it is we did not meet our primary endpoint the way we've set it up. But I think, however, you can glean a lot of information and a lot of important details from this trial that can help set up future trials. Help have informed discussions with patients when thinking about this kind of approach. B, and help to put into context the ongoing trials in this space as well. So certainly, I would say this trial did not change the standard of care, which is what we clearly stated, but it starting to build that foundation and starting to help us understand how we can improve this method to hopefully in the future be able to make this a standard of care for some patients. Yeah, I think the answer is yes. Simply because we know that when we have patients go to surgery and have their bladder removed after chemotherapy, somewhere between 30 and 40% of them have no cancer left behind at all. Can't find any cancer in the bladder. Well, you could have spared those patients a completely life-altering surgery if you knew that ahead of time. That's key. You can really improve quality of life. The problem still remains that you have to select patients correctly. You have to have a crystal ball, right? You don't have that knowledge until you do the surgery. And that is where we're trying to move the needle. So I think we have to improve on this. And I think the way we're going to improve on it is a combination of using circulating tumor DNA, I think, using urine DNA, using better imaging techniques such as MRIs, which has already been done in several trials, having a very regimented cystoscopic approach, and potentially finding other biomarkers as well. So I think that's how you get better at selecting the right patients for this. And I do believe that that this is something we can do in the future. We already have patients who have gone through this trial. In fact, almost half, 46% of patients who went on active surveillance have not had metastatic disease, have not had surgery, have their bladder intact, have not had radiation to their bladder. I mean, that's a big plus for that patient. You have to be very careful at the same time with patients who have recurrence in the bladder, be very aggressive in doing surgery at that point, because one of the things we learn is that most patients who develop metastatic disease on active surveillance actually develop localized disease first. And we have to be very clear that at that point we have to move on to a cystectomy. But I do think this approach is viable moving forward. I just don't think we're quite there yet to recommend that as a standard of care for all patients.